Welcome to the Surgical Educator's Advanced Online Surgery Masterclass. In this deep dive, we will be discussing elaborately on colonoscopy and its diagnostic and therapeutic applications. Allow the words in the podcast to permeate into your mind. Visualize the patient or patients discussed in your mind's eye, or run a mental movie of the patients to have an indelible impression. By doing so, you will experience an immersive and transformational learning experience. This will eventually result in achieving excellence in surgery.
And, achieving that excellence, it really requires completely rethinking what it means to actually operate.
Right.
Because today we are taking a pretty comprehensive journey from the absolute basics of patient selection all the way to complex, life-saving therapeutic interventions inside the colon.
Yeah, and for you listening, just imagine you are piloting a camera through this constantly moving, incredibly fragile, twisting tunnel in the pitch dark.
That's exactly what it's like.
And the walls are actively spasming, right? And just one wrong push against an unseen corner could cause a massive surgical emergency.
Absolutely.
So that is the reality of the environment we're talking about today. It requires just a tremendous amount of precision. So we're anchoring our discussion right on slide 1, which outlines our mission here, basically mastering the art and science of advanced colonoscopy.
Right, and we're being guided by the incredibly detailed slide deck from Prophecy's Dr. B. Selvaraj.
Exactly.
It's really about elevating your clinical foundation. Because to operate safely in that twisting tunnel you just described, you have to completely understand the why behind the procedure long before you even attempt the how.
Which makes total sense. And that concept of why, that takes us directly to slide 2, looking at the indications and contraindication.
Right, the clinical red flags.
Yeah. And the reasons for going in, they make sense. Constipation, diarrhea, unexplained abdominal pain, or searching for a primary tumor.
Exactly. Or if a patient presents with unexplained anemia, for instance, we're basically hunting for a slow, silent gastrointestinal bleed that just isn't showing up anywhere else.
Yeah. Right, a hidden bleed. But looking at the absolute contraindications on this slide, something kind of jumps out at me.
Oh, yeah. What's that?
Well, if a patient has fulminant colitis, meaning, their colon is experiencing severe, rapid onset inflammation, why wouldn't we want to use our best internal camera to see exactly how bad the damage is? Why fly blind there?
That is such a good question, and it's a really critical distinction to make. It basically comes down to the structural integrity or the physics, really, of the bowel wall itself.
Physis.
Yeah. In severe inflammatory states like fulminant colitis or severe ischemic necroses, the colon wall is dangerously compromised. The tissue just loses its tensile strength.
Wow.
Yeah, it becomes incredibly friable. And when you introduce a colonoscope, you don't just slide it in. You have to constantly insufflate.
Insufflate meaning pumping air into it.
Precisely. You have to pump air into the colon to inflate the lumen, otherwise you can't actually see where you're going. So if you pump air into a colon that is already structurally degraded by fulminant colitis, the pressure will literally tear the tissue apart.
Oh my God.
Yeah. The risk of causing a procedure-induced perforation vastly, vastly outweighs any diagnostic visual you might gain.
So the very mechanism required to see the air pressure literally turns the tool into a hazard.
Exactly.
That perfectly illustrates why patient selection is paramount, which means even under normal conditions, simply getting the camera from point A to point B is a massive anatomical challenge.
It really is.
And slide 3 breaks down this navigation. It defines the procedure as inserting this flexible scope up to the cecum, and, it proudly displays a 98% success rate for experienced examiners.
Which is fantastic.
But it also lists obstacles, like a mobile and elongated sigmoid colon or postoperative adhesions. If the success rate is 98%, how hard are these obstacles to actually overcome?
Well, that 98% figure is basically a testament to rigorous training. But those anatomical challenges, they require constant active problem solving in real time. To build on your tunnel analogy from earlier, imagine pushing a flexible hose through a tunnel that suddenly loops back on itself.
Okay, that sounds like a nightmare.
It is. The sigmoid colon is notoriously mobile. So if it forms a loop, and you just keep pushing the scope from the outside, the tip of the scope doesn't actually advance forward.
Where does it go?
Instead, the entire scope bows outward, stretching the colon and the mesentery that's attached to it.
Which would cause immense pain for the patient, I'm assuming, and risks stretching the tissue to the point of tearing.
Precisely. And then you have postoperative adhesions, so internal scar tissue from previous surgeries. That means the colon might be rigidly glued to the abdominal wall in places it normally wouldn't be.
So it won't yield to the scope's pressure the way textbook anatomy says it should.
Exactly. You have to constantly manipulate the scope, apply abdominal pressure, and, change the patient's position to navigate those corners.
Man, that's intense. But none of that careful navigation even matters if the camera lens is staring at a wall of debris.
No, it doesn't.
If we're going to navigate that dark, twisting anatomy safely, we need maximum visibility. And that necessity brings us to the cleansing mandate detailed on slide 4.
The dreaded prep.
Yeah, exactly. The preparation protocol requires a really strict timeline. Patients switch to a low-fiber diet days prior, consume only clear liquids the day before, and adhere to a strict MPO, no food or drink for 2 hours right before the procedure. Why such an aggressive, multi-day wind-down?
Because a colonoscopy is fundamentally a macroscopic visual assessment.
Right.
The mucosal surface we are inspecting is highly nuanced. We are looking for lesions that might be elevated by only a millimeter.
A single millimeter.
Yeah, tiny.
Yeah.
So if there is residual stool, bile, or undigested fiber obscuring the mucosal wall, a flat lesion, which could be a highly aggressive early-stage carcinoma, it simply vanishes into the background.
Wow.
Poor preparation effectively nullifies the entire purpose of the procedure. It's actively dangerous.
Yeah, the idea that a patient goes through this entire invasive procedure only for the surgeon to miss a life-threatening lesion just because of a poor dietary prep, that's incredibly sobering.
It really is.
So how do we guarantee that perfectly clean environment? Slide 5 outlines the standard purgative regimens. It lists high-volume polyethylene glycol, or PEG, like go lightly. Then we have a combination of PEG plus bisacodyl, like half lightly, and finally sodium picosulfate. I know these clear the bell, but chemically, what exactly are we doing to the patient's gastrointestinal tract here?
Basically, we are manipulating the body's natural osmotic and peristaltic functions.
Okay, how so?
Well, polyethylene glycol is a large inert molecule. When a patient drinks 3 or 4 liters of a PEG solution, those large molecules travel through the gut and water binds to them.
Gotcha.
It prevents the colon from absorbing the water back into the body.
Yeah.
This massive volume of unabsorbed fluid essentially power washes the colon from the inside out.
Power washing the colon. But drinking 4 liters of a salty liquid is famously brutal for patient compliance. Is that why this slide mentions adding bisacodyl?
Exactly. Bisacodyl is a stimulant laxative. Instead of just relying on fluid volume, bisacodyl chemically irritates the nerves in the bowel wall, which triggers strong muscle contractions, peristalsis.
Ah, so you're hitting it from 2 angles.
Right. By combining a stimulant with the osmotic wash, we can significantly reduce the volume of that awful-tasting PEG fluid the patient has to consume while achieving the exact same cleansing efficacy.
That makes a lot of sense.
And because this prep, along with the procedure itself, induces significant cramping, the slide correctly notes we utilize IV sedation.
Like midazolam and fentanyl or propofol.
Yes, commonly those, just to keep the patient comfortable and compliant.
So the colon is pristine, the patient is sedated, and we are ready to advance. Slide 6 lays out 5 rules for intraprocedural mastery.
These are crucial.
Looking at them, no view, no advance if resistance, when in doubt, pull back, minimize air, and monitor patient pain, they all seem to point to one central theme. It's less about moving forward and entirely about maintaining spatial awareness and preventing mechanical trauma.
You've hit the nail on the head, like no view, no advance isn't just a polite suggestion. It's practically a law of physics in endoscopy.
Right.
If the screen is red or blurred, the tip of your scope is pressed directly against the mucosal wall. If you push, the scope has nowhere to go but literally through the wall.
Oh, yikes.
Yeah, so you must pull back, reestablish the lumen in the center of your monitor, and only then proceed.
I want to focus on rule 4 for a second. Minimize air. We established earlier that you have to pump air into the colon to see the path ahead. But why is minimizing it a cardinal rule?
Think about it like a long, curved balloon.
Okay.
As it fills with air, it gets longer, thinner, and the tension on the rubber increases dramatically. If you over-insufflate the colon, you elongate the very tunnel you are trying to navigate.
Making it harder to reach the end.
Vastly more difficult.
Yeah.
All while drastically increasing the risk of perforation due to wall tension.
That makes perfect sense.
Yeah.
So as you are carefully insufflating and navigating, you need to know exactly where you are in this elongated tube.
Exactly.
Which brings us to slide 7, covering endoscopic topography. The slide highlights 4 key anatomical landmarks, and it shows that the inside of the colon isn't just like a uniform pink hallway.
Far from it.
Let's start with the transverse colon. The slide notes a distinct triangular configuration with evenly spaced hastrations. What exactly is a hastration?
A hastration is essentially a sacculation or a pouch-like fold in the wall of the colon.
Okay.
They are created by the tenae coli, which are these longitudinal bands of muscle running the length of the large intestine.
And they create that shape.
Right. In the transverse colon, these bands pull the tissue into a very distinct triangular shape. When you see that triangular fold pattern on the monitor, you instantly know you are in the transverse section.
It's like a map marker. The next landmark on the slide sounds almost like science fiction to me. At the splenic flexure, it notes a shimmering of spleen. You can genuinely see the patient's spleen from inside their colon.
You actually can. It's fascinating.
How does that work?
Well, the spleen sits directly against the outside wall of the colon at that specific flexure. Because the colon wall is quite thin, and because your endoscope emits a very powerful light, transillumination occurs.
Ah, like shining a flashlight through your hand.
Exactly like that. You can often appreciate a bluish hue or a shimmering impression of the spleen pressing against the mucosa. It is a vital topographic marker indicating you're making the final turn down into the descending colon.
That is wild. Further down, we have the rectum, identified by its runi lumen and distinct valves of Houston. And finally, the ultimate destination, the terminal ileum. The slide describes its surface as velvety, lacking those pouch-like hastrations entirely.
Yes. And reaching the terminal ileum means you have successfully exited the large intestine and entered the very end of the small intestine. That velvety appearance comes from the villi, the microscopic singer-like projections that absorb nutrients in the small bowel. Seeing that velvety texture is the definitive visual proof that your navigation is complete.
Mission accomplished. So, now that we know how to read the map, we need to know what we are hunting for.
The diagnostics.
Right. Transitioning to diagnostics, slide 8 contrasts 3 distinct types of growths and malignancies. First, we see a flat lesion, which just looks like a very subtle, almost invisible elevation of the mucosa. Next is polyposis, presenting as a massive cluster of irregular, bumpy growths. And finally, colorectal carcinoma, which looks entirely different, an advanced, irregular, hypervascularized mass.
Yeah, that's a very clear visual difference.
Why does the carcinoma have so many highly visible blood vessels compared to the others?
Because malignant tumors require massive amounts of energy and oxygen to sustain their rapid, uncontrolled cellular division.
They need fuel.
Exactly. To get that energy, carcinomas secrete growth factors that force new, irregular blood vessels to form and supply the tumor directly. This process is called angiogenesis.
Wow.
Yeah, and that chaotic, hypervascularized surface is a very clear hallmark of advanced cancer.
Which makes it relatively easy to spot, right? But the slide specifically notes that the flat lesions require dye spraying techniques, known as chrome endoscopy, just to define their borders. How does spraying dye help you see a flat growth?
Well, flat lesions don't protrude into the lumen, so they don't catch the light from the endoscope the way a normal polyp would.
Okay, so they hide in plain sight.
Right. So chromoendoscopy involves spraying a contrast dye, like indigo carmine, directly onto the tissue.
Does it stain the cancer cells?
No, the dye doesn't actually stain the cells. Instead, it pools in the microscopic crevices and pits of the mucosa. By pooling in the margins around the abnormal cell growth, it visually outlines the precise borders of the flat lesion.
Allowing the surgeon to target it for biopsy or removal?
Exactly.
It acts like a topographic highlighter. That is so clever. Now, growths aren't the only pathology we encounter. Slide 9 shifts the diagnostic spectrum to inflammatory conditions. On the left, we have Crohn's disease and ulcerative colitis, characterized by severe mucosal inflammation, deep ulcerations, and a pathological thickening of the colon wall.
It looks incredibly angry and raw.
Yeah, really severe. But on the right side, pseudomembranous and ischemic colitis look entirely different. The slide notes a loss of the vascular pattern, severe friability, and necrotic tissue.
The visual difference reflects a completely different disease mechanism. Crohn's and ulcerative colitis are driven by an overactive immune system attacking the tissue, which causes the swelling in deep ulcers.
Okay.
Ischemic colitis, however, is basically a plumbing problem. The blood supply to that segment of the colon has been choked off.
Oh, wow.
Yeah, without oxygenated blood, the normal submucosal vascular pattern just disappears and the tissue begins to die, which is why you see that necrotic, sloughing tissue.
And instantly recognizing that visual difference dictates exactly how you manage the patient. But finding the pathology is only half the battle. Now we step into the role of the operator.
The therapeutic side.
Right. Slide 10 covers therapeutic intervention, tissue resection. The slide contrasts snare polypectomy with endoscopic mucosectomy. For pedunculated polyps, meaning polyps that grow on a stalk, kind of like a mushroom you use a snare, you loop a wire around the stalk, pull it tight, and apply electrocautery to burn through the tissue while simultaneously sealing the blood vessels.
It's very effective.
But for those flat lesions we highlighted earlier with the dye, you can't just lasso them. The slide shows mucosectomy being used, specifically noting a fluid injection prior to the snare. Why inject fluid under the lesion?
It is a vital safety mechanism. You see, a flat lesion sits directly on top of the deeper muscle layer of the colon wall.
Okay.
If you try to snare it flat, you will almost certainly grab the muscle layer, cut through it, and cause a massive perforation.
Which we definitely want to avoid.
Exactly. So by injecting a specialized fluid solution into the submucosal space beneath the lesion, you create an artificial cushion. It physically lifts the abnormal tissue up and away from the muscle, creating a safe buffer zone. So you can snare and excise the lesion without breaching the structural integrity of the bowel wall.
That is brilliant mechanical problem solving.
Yeah.
Speaking of mechanical solutions, what happens when a malignancy isn't just a polyp, but a massive tumor physically blocking the colon?
That's a very dangerous scenario.
Yeah. Slide 11 details the intervention for malignant strictures and stenosis. It shows a severe stenosis at the rectosigmoid junction. The lumen is basically choked off. The slide then demonstrates bouginage using dilators to stretch the opening, followed by the deployment of a self-expanding metal stent, or SEMS.
Right.
How does a collapsed metal tube exert enough force to pry open a malignant tumor?
These stents are typically made of specialized alloys, like nitinol. Yeah, they have shape memory properties. They are compressed tightly into a delivery catheter. Once the catheter is maneuvered through the stricture, the stent is deployed.
And then what happens?
As is released, and as it warms to body temperature, the metal mesh forcefully expands back to its original tubular shape. It provides constant outward radial force, slowly prying the tumor apart and keeping the lumen open.
That's incredible.
It really is. This allows the bowel to decompress, which often saves the patient from needing an emergency, high-risk open surgery, converting it into a much safer elective procedure later on.
You are fundamentally restructuring the anatomy from the inside out. But anytime we are cutting tissue or prying tumors, bleeding is a major risk, right?
Always.
Slide 12 tackles hemostasis with thermal and injection techniques. We have two very different tools here. The first is the injection gold probe. It has a retractable needle that allows you to inject epinephrine directly into the bleeding site, followed by a spiraled electrode for coagulation.
Yes.
How does injecting adrenaline help stop a bleed?
Epinephrine is a powerful vasoconstrictor. When you inject it into the submucosa around a bleeding vessel, it causes the surrounding blood vessels to instantly clamp down and spasm shut.
Oh, I see.
This immediately slows the bleeding pool, which clears your visual field, allowing you to deploy the gold probe's thermal electrode directly onto the precise source of the bleed to permanently seal it.
The second tool on this slide relies on a completely different physics principle. Argon plasma coagulation, or APC. The slide describes it as non-contact coagulation, used for things like angiodysplasia, which are, abnormal enlarged blood vessels in the GI tract.
Exactly.
And the probe is held millimeters away from the tissue.
APC is remarkable. The catheter releases argon gas, and a high-voltage spark ionizes that gas, turning it into a plasma arc. It conducts electrical current directly to the tissue without the probe ever actually touching the mucosa.
So it's essentially a microscopic, non-contact blowtorch.
That's a great way to put it.
And because the probe never touches the tissue, when you turn off the plasma and pull the tool away, there's no risk of accidentally ripping the fresh blood clot off with the instrument.
Exactly. The non-contact nature makes it perfect for treating broad areas of superficial bleeding.
But sometimes thermal energy isn't enough, right? Sometimes you need mechanical clamping.
Yes, for larger vessels.
That brings us to slide 13, endoscopic hemoclip application. The slide breaks this down into 6 distinct stages. And stage 1 immediately caught my eye. Wash off the blood clot to expose the site.
Yeah, that surprises a lot of people.
It seems completely counterintuitive. If the body has formed a clot to stop the bleeding, why on earth would you blast it away with water?
It's a really common misconception, but a superficial clot in the gastrointestinal tract is often just a weak, temporary dam hiding an active arterial spurt beneath it.
Oh, wow.
If you blindly deploy a titanium hemoclip onto a mound of clotted blood, You aren't clamping the severed artery, you are just clamping jelly.
Which obviously won't hold.
Right. The clip will fall off and the bleeding will resume. You must vigorously watch the site to visualize the actual millimeter-well defect in the vessel wall.
So you wash it away to reveal the true target. Then, according to the slide, you identify the vessel, advance the open hemoclip, gently position it over the vessel margins, close it securely on the tissue, and release it from the applicator. It's a highly methodical sequence.
It has to be. You are operating in a dynamic, actively bleeding environment. Precision and patience are absolutely paramount.
And speaking of environments requiring extreme patience, let's look at slide 14. Complex retrievals for foreign bodies.
This is where things get really challenging.
I bet. The first scenario is rectal impactions, where extraction forceps are used to remove solid objects. The slide explicitly warns of a high complication risk. Why is pulling an object out so dangerous?
The rectum and the sigmoid colon have very complex curves. If a solid, rigid object is lodged inside and you simply grab it and pull straight down, the rigid edges of that object won't follow the curve of the bowel.
What happens instead?
They will act like a spear, piercing straight through the bowel wall and causing a catastrophic perforation.
Oh, geez. Which brings us to the second incredibly high-stakes image on the slide, body packer retrievals.
Yes.
This refers to patients who have ingested or inserted narcotics concealed in fragile latex pouches or condoms, which have migrated into the colon. The slide mandates they be handled with supreme caution to prevent pouch rupture.
Yes, supreme caution is an understatement.
How do you extract a fragile drug-filled balloon using metal surgical tools without bursting it and causing a fatal overdose?
Well, first of all, you never use standard sharp snares or tooth forceps. You utilize specialized retrieval nets or soft rubber-tipped graspers.
Okay, so gentler tools.
Right. And you must capture the pouch with minimal tension. The real skill is not in the pulling, but in working with the body's natural peristalsis.
Letting the body do the work.
Exactly. You gently maneuver the pouch while slowly withdrawing the scope, allowing the bowel to naturally guide the object around the flexures without applying direct shear force to the fragile latex.
That requires just an incredible combination of anatomical knowledge and physical finesse. We have covered an immense amount of ground today. Let's pull up the penultimate slide, slide 15. This is the master infographic. As instructed at the beginning, this is where you run that mental movie to really lock in the learning.
Right. Let's synthesize the timeline. You begin by securing the clinical foundation, understanding the why, and ensuring no absolute contraindications like fulminant colitis are present.
Right.
You mandate a flawless preparation protocol using osmotic and stimulant purgatives because residual debris renders the diagnostic visual completely useless. You advance the scope adhering strictly to the interprocedural rules, never advancing without a clear view and minimizing error to prevent trauma.
And as you move, you map the endoscopic topography, recognizing the triangular hostrations of the transverse colon and utilizing transelimination at the splenic flexure.
Exactly. You utilize your diagnostic spectrum, employing chromoendoscopy to highlight the borders of subtle, flat lesions, or visually diagnosing the necrotic tissue of ischemic colitis.
Yeah.
And finally, you execute your therapeutic interventions. You inject submucosal cushions to safely snare flat polyps. You deploy self-expanding metal stents to pry open malignant strictures. You harness argon plasmal to seal bleeding vessels, and you execute high-stakes foreign body retrievals with absolute precision. This infographic represents the complete continuum of care.
It truly is a masterclass in spatial awareness, pathophysiology, and real-time problem solving. Before we close, considering all the intricate visual diagnosis we've discussed today, what is the next frontier for this procedure?
You know, I want you to consider the intersection of these manual techniques and machine learning.
Oh, interesting.
We spent considerable time discussing the difficulty of spotting millimeter-high flat lesions amidst the mucosal topography, right?
Right, they hide.
In the very near future, real-time AI mapping will be integrated directly into the colonoscope's video feed. It will instantly highlight abnormal cellular patterns and flat lesions that are virtually invisible to the naked eye.
That's game-changing.
It is. The future surgeon will transition from being a visual detective into a pure master therapeutic operator as the AI instantly flags the pathology for immediate resection.
A fascinating paradigm shift to prepare for as the technology evolves. That concludes our deep dive into the masterclass slide deck. Kindly like, subscribe, and share this video on your social media and press the bell button to get notified regarding my latest uploads. Wish you all a great learning experience. Thank you.